Good afternoon and welcome to our Cardiac and Vascular Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be the moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Juan Lopez. Dr. Juan Gabriel Lopez, who is also presenting on the lecture, who's presenting on Echocardiographic Strain. Dr. Juan Gabriel Lopez is a board-certified cardiologist at Baptist Health Miami Cardiac and Vascular Institute, specializing in complex cardiovascular conditions, echocardiography, and preventive cardiovascular health. Dr. Lopez earned his medical degree from Florida International University, Herbert Wharton College of Medicine, and completed his internal medicine residency at University of Miami Jackson Memorial Hospital, where he earned the Intern of the Year Award in 2018 and the Derek J. Saifi Award in Research for Daytop Clinical Research Award in 2019. Dr. Lopez then went to complete his fellowship in cardiology at the University of Miami Jackson Memorial Hospital. He co-authored a book chapter in 2023, which is titled Mastering the Structural Heart Diseases, and has published research in journals such as Circulation Research and the American Journal of Cardiology. Dr. Lopez has been a speaker in local and international conferences and summits. He is, of course, bilingual, and we are thrilled to have Dr. Lopez with us. Thank you so much for your time and for being with us today. And I'm sorry about the little mishap with reading your bio. Welcome, Dr. Lopez.
Thank you so much for having me. Please do not be concerned of any of these things. So the topic I have chosen to discuss today will be on echocardiographic strain. So as opposed to many of the topics that we discussed, this is a topic that I think is more on the frontier of things. So I wanted to just shed some light, maybe explain. I think it's, in general, it's a little bit of a dense topic and doesn't get a whole lot of coverage. So just to see the ways that we are progressing with the development of strain. To begin, I have no disclosures to go through. And the agenda for today is really discussing the foundations of cardiac strain, where it comes from, what it even means in the first place, then illustrate the current strain-based applications that we're currently using in our day-to-day practice. I think no discussion in strain is complete if we don't discuss some significant limitations that we have available, or some significant limitations we have currently. And then as well, we'll be talking about kind of some future applications of strain and where the direction of echocardiographic strain is headed. So we're going to begin with the foundations of strain. So to begin, what is strain? So when we're talking about strain, I like to usually start with the physics and kind of when it was first described. So it was applied, it's actually a term in physics that we use to describe a deformation to a certain stressor. So whenever we have a material, and material science in particular, whenever material either extends or shortens, we have what we call strain and stress relationship. We first applied it to the heart back in 1973. This was done obviously not through echocardiography, but done during pathology studies. And really what it signifies is a change in length over the total length. It's a dimensionless value, but it is not associated with a unit of measurement. We usually describe it as a percentage for simplicity's sake. And it occurs in every single plane of force. So in a heart or any three-dimensional object, strain obviously occurs in at least the three different directions. When we think about the heart, one of the things that we talk about is circumferential strain, which you'll see here over to the right. So circumferential is the rotation of the heart. We also have the radial strain, as in the contraction, and then the longitudinal, which is the in and out from the apex to the base. How do we acquire strain? So the initial way that we did this was through tissue Doppler imaging. Basically, we looked at how the particle, in particular, we use this on a daily basis whenever we're looking at our subtle and lateral tissue Dopplers to see the mitral excursion, and then we also applied it to the tricuspid excursion. But initially, strain was applied via the Doppler effect. The problems with these is that this is very limited due to the angle dependency of the ultrasound beam. And it only evaluates really that longitudinal strain. It only gets from coming down, but it doesn't really, it's not very good for capturing the circumferential strain and that radial strain that we were talking about. Noise creates a very big limit, and it really required significant expertise to read, as well as the tethering effects, which we always see whenever we're talking about our mitral excursions, in particular from things like valves, the pericardium, and whatnot. So this was the initial stage when we talked about strain. This was the initial development. And then we moved on to a little bit more of a, not more complex, but maybe a little bit more elegant method of doing this. And this is a method that we currently use, which is a two-dimensional speckle tracking. We basically see where in an image, there's a speckle that's found, and then we see where it moves. One of the limitations of this is, well, tachycardia due to kind of the movement artifact and how fast these things move. But in particular, also the fact that there is an angle, even though it's angle independent because it's in two dimensions, three-dimensional, it's a three-dimensional structure. So there is some variability when we're looking at these speckles. So it's not all that, it's not perfect to say. Now, our current clinical applications of strain. So I think overall, and even when we've traveled with Baptist Health International, I've gathered that a lot of different places are starting to see more and more use of this. These are currently the things, the current applications that we have on a very routine basis. And here on the right, you see how we capture these strains. Sorry, let me go back. So we have cancer therapy. So whenever we're evaluating patients for cancer, we have bullseye pattern recognition for particular diseases. We'll get into some of these a little bit more as we go through the presentation. And then as well as athlete's heart and hypertrophic cardiomyopathy. So when we talk about cancer-related therapy, so we give, one of the things that we do when it comes to this is have a baseline strain. And then we will proceed to, after every cycle in the particular cardiotoxic medication, repeat the strain. Now, this will be due to some of our limitations, as we'll see later, but whenever we do this, we're very particular about using the same vendor and same software to try to get a consistent number between patients. And then one of the main things and criteria is that whenever you have a change of the baseline by more than 15%, these are significant. Now, I think one of the things I always like to clarify is what that 15% means. So usually our numbers are normal between 21 and 24%. So it's not going from 21 to, let's say, 6%. It's really a 15% decrease from 21. So here I gave the example of 23%. So if you go a 15% decrease, just a GLS or a global longitudinal strain of 19.5% is already a significant deformation. And at that point, this will require that discussion with our colleagues in oncology and our cardio-oncologists for determination of whether we need to slow down medication, change medications, or if it's okay to continue with medications and just modify some of that therapy. So this is I think this is the hallmark use of strain pretty much across the United States. We use this, like I said, almost as a routine at this time. The other one is, and really the main other one, is kind of that pattern recognition. I think now more and more we're aware of the different patterns. So on the top here, A1, A2, A3, A4, we have a different pattern, which is colloquially known as a cherry on top. So it's a red apex, meaning a hypermobile apex, and then you have more of a, not a hyperkinesis, but just a decrease in the strain over at the bases in the mid wall. And this is mostly consistent with amyloidosis. On B1 and B2 here, as you can see over at the anterior septum and even some of the inferior septum, you have these decrease in uptake. So obviously red is the normal color. When we talk about strain, rain is a normal movement. And then white, when you go towards the whites and blues, that shows decrease in that strain. And here in that septum, you really have that decrease of strain. And these are things that you might particularly find in hypertrophy. In particular, hypertrophic cardiomyopathy, whenever you have that septum that's hypomobile, you will pick up on those abnormal strains over the septum. C1 and C2, when these are much more non-specific and varying, and these are particularly done in aortic stenosis. But again, this is not a significant pattern, but we can see how these things are kind of would change. So, whenever we have a patient that we're suspecting amyloidosis in particular or hypertrophic cardiomyopathy, echo patterns and these strain patterns really become paramount to our diagnosis, and it's a much quicker and easier way to have an assessment rather than going down the PYP or biopsies. And it really gives us some information on the uptake. And then along this discussion with hypertrophic cardiomyopathy, whenever we do have a sports cardiology program, and in those patients, whenever we have trying to distinguish between hypertrophic cardiomyopathy or if it's just an athletic heart, this is another place where strain becomes significantly important. If we see that a patient has, the hypomobile anterior septum or septum, we're much more suspected of hypertrophic cardiomyopathy. But if they have a normal strain pattern and the walls are thick, we think that this is, this gives us more reassurance that these athletes, they're just athletic hearts and not necessarily hypertrophic. Obviously, we do this in conjunction with cardiac MRI. But again, this is just another piece of the puzzle, and it's starting to grow and gain more traction as time goes on. Now, limitations, once again, when we talk about the limitations, strain in particular carries a significant amount of limitations, and that's why we don't have it in every single guideline, and it's not what seems to be such a growing field. In particular, back in the beginning in 2009, with this, there was an attempt to create baseline normal values. The European Association of Cardiovascular Imaging and the American Society of Echocardiography actually convened a task force a couple of years back, and they basically brought all the different companies to try to see if we can standardize this and have some improvement. And really, they wanted to assess how much variability there was in cycle tracking echocardiography. And this was just, again, one big way of getting that discussion going, to homogenize our strain software and our protocols. When they looked at all these different things, we found that there was a decent inter-machine variability, and there was a significant difference between the machines, and the highest difference ranging about 4 percentage points, which is a significant amount. As we discussed previously, that is enough to say whether the patient has had more than a 15% decrease in the global longitudinal strain. And for that reason, we do not, it creates some significant limitations, and that's why we use that same provider, same machine whenever we do these studies. They also looked at variability by looking at independent software. So we looked at software that was vendor independent and it was reproducible. So it really seems like the majority of the variability comes on the software end, as how we are measuring and how we're counting the speckles, and also how they're being averaged out. So leaning forward, I think that this is something that still requires a lot of work to be done, a lot of things to develop. And once we really have this hammered down, we will see a much bigger, maybe not a renaissance, but more of a development on the strain technique. Now, when we get that solved, there's a couple of things. Well, there's a couple of ways that I think speckle can become more homogenized. And then one of them is the advent of the 3D speckle tracking. Right now, it's kind of limited. Not a whole lot of places have it. We're trying to actively get it so we can do a little bit more with this. When we have a 3-dimensional image, we get an improved acquisition, improved assessment of these speckle patterns, and it should reduce some of the variability from the machines. I didn't include it on this presentation this time around, but along the lines of 3D speckle tracking, another thing that we can potentially use is actually something called strain rate. I didn't want to go into it because that's a whole discussion on its own. But strain rate basically is also, I believe it's going to be one of the ways we can independently remove some of these limitations. So that's another thing that's currently being developed. So that was from an acquisition standpoint, but what are the future directions of where we can be using these things? So we're currently developing some studies that involve some of these future directions. So one of them is the detection of coronary artery disease. Strain is actually one of the first things that occur, or strain dysfunction occurs early in an MI. So it actually allows us to have early evaluation of MIs. So that's one of the ways that we can detect myocardial infarction. Cardiac asynchrony. So here on the left, you see whenever you have a wall that moves away, you can see when we have that cardiac asynchrony. And then optimization in cardiac resynchronization therapy. So these are the things that we're going to talk about. I didn't go into much detail, but one of the things is the timing of when the walls move is a way that we can also try to bring this into using cardiac resynchronization therapy. So we're seeing that one of the walls and at least optimization of that interventricular dysfunction or timing is one of the ways that we can use strain to further optimize. Again, these are still very much in the works in the research realm, and not things that we're currently using in our day-to-day, but it might eventually, as we develop these, could potentially also offer some options for left ventricular strain. Now, left atrial strain is the next one. So any chamber can really be applied the concept of strain. Left atrial strain is something we're currently also trying to use a little bit more. And it actually helps us. There's two ways that we're really using left atrial strain. So one is the evaluation of diastolic dysfunction, as of the most, as of our diastolic guidelines, as well as the European guidelines. The use of reservoir strain is a way to further assess for elevated swelling pressures in the atrium and the contractility of the atrium. The other one is in the contraction or the contractile part of strain from the atrium. So some studies have shown that this is an independent predictor of AFib recurrence after ablation. So this is another realm where we're actually trying to look into a little bit more. And we're again developing studies to look at post-ablation, assess the recurrence of AFib by looking at strain and particularly that left atrial contractility. As you can imagine, as you lose the contractility of the atrium, it's more of a predictor for going into atrial fibrillation. Right ventricular strain. So this is one that, like I said, applying it to all the different chambers. It's useful in pulmonary hypertension, and at least it's being evaluated in pulmonary hypertension, heart failure, and also ARVC. For heart failure, it's actually a very good or it's been studied for predictors in LVAD. Whenever we use a left ventricular assist device, one of the dreaded complications of an LVAD is RV failure. So this is a good way to find out the prognosis of patients before going into a left ventricular assist device implantation and seeing how they will do. So again, research things that we're developing and we're moving forward to kind of iron out in the future. So again, this is an overall relatively quick evaluation on strain. Each one of these topics I think will require a significant amount of time and its own discussion. But I just wanted to kind of go over strain itself in a very overall quick way, just to bring an appreciation to what strain is, how much we're evolving on this, and really bring it to the forefront. Currently, a technique that has immense potential. In particular, I think I see it, as we develop, now we're getting more of the artificial intelligence side. I think that maybe some of these detection techniques will continue to get better. But that doesn't take out the question that we have significant amount of hurdles, reproducibility, generalizability, and really having this on every single front is one of the limitations that we have. And then once we have that consensus, I think that all these types of strains will become increasingly studied and then applied to our different pathologies and therapies and guide us a little bit better down the future. And with that being said, I'm going to open this to questions and answers with Dr. Hakim.
Thank you, Dr. Lopez. What an interesting technology. One thing that I wanted to just highlight, and it's the fact that you use it in lieu of the traditional echocardiography for cancer treatment or for patients on cancer treatment that require
Right.
echocardiography. Now you use this technology.
Right. So we do echocardiography, and then we proceed to do it as part of our studies. So it's just an addition to our studies.
Uh-huh.
Right now, it's still not all of us are reading particular strains, but it's something that we're currently actively training all our staff and everybody to do. But in the particular cases, like I mentioned, uh, oncological,
Sure.
athletics, or hypertrophics, as well as amyloid, these are things that we're actively doing on a daily basis, and it's an addition to our echocardiography.
Right. So in essence, we can safely say that this technology is not necessarily available throughout the Americas at this point.
I was when I was in El Salvador recently, and we were talking about these things. They're starting to be used, but I think some of that technique is still arriving at this time.
Mhm.
I think it's still being developed. From my experience so far, I'm glad to hear if anybody has anything else to offer.
Right. So Dr. Lopez, so you can help us understand how this particular type of imaging can obviously support the oncologist in the process of actually providing the next dose and the chemotherapeutic agent that is required. You did mention, I believe, that you can not only determine already, like the threshold where the patient is developing already or going into a chronicity of a condition or developing a new condition. And you did mention that 50% is already a chance between of determining that 15%. If the result is at 15%, then there is perhaps a
Damage.
iatrogenic type of results
Right.
from the. Okay.
Right.
So
So the way it works for us is basically screening we use as a kind of a sentinel marker. So
yeah,
whenever we're having patients with cancer, the last thing we want is their ejection fraction to drop, particularly with the chemotoxic therapies. So this is a way for us to find out early that if their hearts are susceptible to the therapy, and we can find out before they drop their ejection fraction. So
right.
in order to try to recover the ejection fraction, or trying to do medications, we can either prevent, slow down, or adjust before we get to that point. So it's a way
I
for
see.
us to find out cardiotoxicity a little bit earlier than we were doing before, and it gives us that ability to prevent lasting damage.
So you write an order for a baseline study before you start
Yes,
the
yeah,
therapy in order for you to
mm-hmm.
obviously compare to the baseline.
Right, right.
Gotcha. Gotcha. That is quite an interesting thing. And you did mention also that obviously you are able to use the study to determine issues such as amyloidosis and also any other issue with the myocardium, such hypermotility.
Hypertrophic,
Yep.
right. And
Uh,
then the amyloid is something that we're also using a lot more just because now we have human therapies for amyloidosis.
right.
So now we're catching it earlier due to this, right? So whenever we do our strains and we catch these patterns, we're actually trying to catch them as early as possible so we can start the tafamidis, the medication for amyloid, in order to prevent long-term effects from amyloidosis.
Mm-hmm. And if I may, I mean that sounds like a phenomenal tool simply because you're able to actually view each one of the chambers and the conditions that potentially that chamber can end up suffering from, and perhaps predict, if not at least have some kind of a baseline for other conditions such as congestive heart failure when you're studying, for instance, the right ventricle and so on. Is that the
Right.
case as well?
Yeah, it's the case. And again, I think that strain has a significant amount of limitations, like I mentioned. So while we're working on some of these, and that's why it's not so omnipresent as some other things we have, but it's definitely something that we're continuing to develop. And in spite of the limitations, it's showing to have significant impact on our day-to-day therapy and diagnostics.
That is amazing. And but you did mention also something important that you have to use the same platform or the same technology in order for you to be able to compare it. So if you do a study in your machine and the patient goes to another cardiologist and has something completely the opposite, would not necessarily be adequate to compare.
Correct. Correct. So yeah, the acquisition and the expertise of the text as well as the machine itself, the software. If you're using different softwares, that can give you that can maybe exacerbate the significance of the changes. so it's
Right.
not accurate. So we would, even if someone has had a strain done before, particularly with the oncology patients, we will repeat it on our own machine if they're going to be continuing care here longitudinally.
Mhm. This has this become like a gold standard or the go-to type of technology for any condition that you know of or that you have experienced that it has a great potential to use it in?
Yeah, so I mean the ones that I mentioned, so oncology,
Definitely in
amyloid,
oncology.
and hypertrophics are pretty much part of guideline at this time.
Yeah.
Left atrial strain is part of the European guidelines, not quite in the American guidelines. We haven't had an update in that since about 2016 or 2017. So I'm sure in the upcoming guidelines we might start seeing some of that left atrial strain as part of our kind of algorithm for diagnosis of diastolic dysfunction.
That's remarkable. Have you already explored or have you heard of any advancement in this particular technology? Were you excited? What are you excited about the future of this particular technology?
So personally, I've been one of the things that, like I said, we're trying to work up is both in the diagnostics and the therapies. You know, one of the things I'm interested in is developing a little bit more of what I mentioned earlier, which is strain rate. So I think that that has a significant amount of potential. It's just right now I don't think it's very well understood or very well described. So I think as we develop that further, I think it will give us. I think some of the limitations that we're facing with strain will be removed to some degree, just kind of based on how that is interpreted. But right now we're, like I said, now it's still a work in progress. So and that's very exciting, right? So I think that moving forward,
Mhm.
and like I said, in combination with artificial intelligence and whatever's coming down the pipeline, this will continue to improve at a significant pace. And I think it will be much more beneficial than, for example, ejection fraction and all these other things that we use as the standard right now.
That is quite remarkable, and I know that you guys are pushing really, really hard, especially on the AI component or the artificial intelligence, for that matter, and that
Mm-hmm.
is going to definitely change the entire paradigm of the way we diagnose and treat patients. So, kudos to you. We're so thrilled to have you and be able to actually count with your expertise, especially for the Miami Cancer Institute in combination with MCVI, the Miami Cardiac and Vascular Institute.
For
This
sure.
is quite remarkable, Dr. Lopez. Any final thoughts in regards to what you're looking for forward in the future, aside from this particular technology and in combination with AI? Anything that you would like to share with us about the future?
Ooh, so AI is, I think anybody, when we talk about AI, it's always there's so much opportunity. I think we're going to really go through an explosive growth in the next decade. And I think this is truly one of those inflection points in history where we'll look back in the next 10 years, really the technology that we have available will be so vastly different. You know, we're looking at AI right now in our office, right, for our encounters. So our encounters, we do have AI that help us as we do our encounters, auto-populate, essentially do the notes for us or do all the documentation for us, just based on a discussion. You know, we're building that up. There's also echocardiography is going to get better, you know, detection of EKG or artificial intelligence with EKG and detection of problems at an earlier stages is going to become much more prominent as well. So I think that all these things are coming down the pipeline, and you know, even stethoscopes. We have stethoscopes now that have the artificial intelligence, so that even by listening to a patient's heart, it tells you that they have severe stenosis, and with time, we'll probably going to tell you how severe it is. You know, like what the aortic valve area is, just by a physical exam as aortic as artificial intelligence develops. So truly incredible times, and I truly don't know what the future will bring. Whatever I imagine, I think I'll be undershooting what the reality will be.
We agree with you, Dr. Lopez. Not long ago, when the Da Vinci came out and everybody started up in arms, yelling, you know, this is experimental, that is crazy. How can we substitute laparoscopic for this, and so on? And now it has become like a second nature to
Standard.
physicians.
So
And then obviously changing from open heart procedures for a CABG to minimally invasive. That also
yep.
was like frowned upon as how dare you consider that.
Yeah,
And has become one of
every
our
single day. Every
Exactly.
single day we have minimally invasive bypasses. So it's pretty standard for us now. Yeah.
Yeah, it is quite
Great.
remarkable, and we're very, very excited for the entire team at Miami Cardiac and Vascular Institute. Thank you so much for your time. Thank you for your presentation, Dr. Lopez, and for accepting our invitation. I enjoyed you tremendously when we were in El Salvador. I look forward to our next conference abroad. But again, thank you so much for sharing this information with our viewers. And to all of you for participating, thank you. If you have additional questions or you're intrigued about this technology, please make sure to send us a note at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We'll make sure to send them to Dr. Lopez for him to elaborate. And if you want to refer someone for this type of diagnostic tool, then please contact us at Baptist Health International, and we will be more than happy to assist you. We look forward to seeing you all in our next Cardiac and Vascular Institute lecture series, which is scheduled for Wednesday, May 8th of this year, of course. Thank you once again, and have a phenomenal afternoon. Thank you so much, Dr. Lopez. We'll see you around.
Thank you, Dr. Hakeem. Thank you so much.
Thank you.
Thank you for having me.
Of course, anytime.